Good morning, everybody. I have that it's 11 o'clock, so we will go ahead and get started. I am recording this session. I am Patty Taylor with the Dallas-Fort Worth Hospital Council Foundation. I'm the Director of Quality and Patient Safety, and I organize the Sepsis Strike Force Committee that has brought you this presentation. So we thank that committee very much. Two of our speakers today are both on the committee, and we really appreciate them offering to do the first session. We plan on having many sessions throughout the year, so stay tuned for the upcoming events that we're trying to have monthly for you and offer CNEs for free. So thank you again for joining us. I was able to figure out how to mute the entire audience and not have you do the cameras, so I'm proud of myself for figuring that out. At the end, I will turn the mics back on so that you can ask questions. But if you have questions when you think of it and don't want to forget, you can chat them in and I'll be monitoring the chat for questions at the end. We will be, as I said, recording this session. We will place it on our website for you if you wish to view it later. You will not be able to get a CNE for it, though, if you view it later. We will be monitoring attendance today in order to provide that CE certificate. And at the end of the presentation, more information will come on how you can claim your certificate. So at this time, I would like to introduce our first speaker, Jessica Aguilar. She is a nurse and has been one for 6 years, and she currently serves as the backbone of the JPS sepsis team. Her background experiences include pediatrics, education, and emergency medicine. Prior to becoming an RN in 2015, she was a licensed paramedic and a licensed EMT. She's a wife and a mom to a 6-year-old and recently added a fur baby to her family. In her limited spare time, she and her husband are building a photography business. So at this time, I am so happy to turn it over to Jessica. Thank you, Jessica.
Thank you, Patty. I really appreciate that. Thank you so much. And thank you to everybody for joining us for our inaugural DFW Hospital Council and JPS collaboration. So this is a nurse's story. So just a few housekeeping things. This is a approved CE by JPS and DFW Hospital Council. The JPS Health Network is accredited with distinction as a provider of continuing professional development by the American Nurses Credentialing Commission on Accreditation. This activity is approved for 1 contact hour of nursing education. So in order to receive credit for this, you have to be present the entire time and then complete the evaluation. And evaluations will be sent out with a link for the completion of the survey. So this is maternal sepsis. It is, Carrie Hood is the story part of this. It's very powerful and we're very excited to share it with you. But as Patty introduced me, I am the clinical sepsis nurse and I work alongside Kathy Watts. We do not have anything to disclose. We have no conflicts of interest and we're not being paid for this presentation. So the objectives for maternal sepsis. Our first objective is that we want to define the risk factors for maternal sepsis. So what makes maternal sepsis really different from sepsis? We also want to look at our SIRS criteria. We know that SIRS criteria for our septic patients can be different from what maternal sepsis presents as, and we'll go through that in a little bit as well. We want to differentiate between the 3 phases of sepsis. So you have sepsis, severe sepsis, and septic shock. So we're wanting to differentiate between the 3 of those. I just want you to take one thing back if you can and apply it to your current nursing practice from Carrie's story. It's very powerful and there's lots of great takeaways. So find one thing if you can and take it back to your nursing practice. And then we want to identify sepsis in our post-delivery, post-C-section patients. So that's something that is a lot of this story. So just keep that in the back of your mind. All right, so what is maternal sepsis and what makes it so risky and so dangerous? So we talk about no prenatal care. So this can be no prenatal care through the pregnancy to labor. It can be no prenatal care in the first trimester or second trimester. but it puts you at an increased risk for preterm labor. So one of the things that we really want to hone in on is that a lot of group A and group B strep can be diagnosed early on in your pregnancy. Well, if it's not diagnosed, as well as some STDs, it can actually cause damage over time to your baby as they're in utero, as well as upon delivery. So just we're just wanting to watch that. We also want to watch for any skin infections, as well as this can be life-threatening to the mom and the baby if it is undetected. Chronic conditions like diabetes, hypertension, obesity, and COPD put them at a higher risk for developing sepsis, as well as maternal sepsis. Socioeconomic status, and I talk about this because at JPS we have a whole slew of different SES backgrounds that are in the JPS zip code. Sometimes if they do not have the accessibility to be able to get prenatal care, sometimes if they have those chronic conditions like diabetes and hypertension, that makes their pregnancy become high risk. If they have a high risk pregnancy, are they seeing a high risk doctor? Is this something that they are being monitored for? And then lack of running water available. I put that on there because hand washing is one of the most common things that we educate on to prevent sepsis. So if we have no running water available, it's very hard to keep clean and then cut down on those bacteria that are on our hands that live if they're not washed. Residing in a group home, jail, or being homeless. And this one kind of hits home to our JPS people, our patients, clientele. If they are in a group home or a jail, or even if they're homeless and they become pregnant, chances are that they probably have not had prenatal care, or they didn't know they're pregnant, but they're not getting the access they need to care. And so this group, this group has a high chance of having a high risk pregnancy because of this. If they do drugs while they're pregnant or after, it can be detrimental to the baby, especially if the baby ends up being a low stimulus baby because they were born while drugs were in the system for the mom and they found them in the meconium on the first diaper. So we want to be real careful about that. So intrapartum and post-delivery C-sections. So if you have a C-section, we want to make sure that scar is clean, dry, intact, no redness. Carrie will share this part in her story. Vaginal delivery, sometimes they have perineal tears, stage 1 to 4, and depending on that and how it's healing, we just need to make sure that they have that education as well, because this is a huge risk factor for sepsis. And then any stress to the mom. So if the mom has stress, then it kind of goes to the fetal stressors as well. So we want to make sure that if there's stress to the mom, that we're monitoring the baby as well. And then English as a second language. DFW, our hub here, has a large speaking of Vietnamese, Burmese. We have a high Spanish speaking population. So in order to communicate with our patients about the sepsis risk factors, make sure you're going to use an interpreter, document use of that, and make sure it's a licensed, certified translator, not just like a family member, because that gets into another realm of patient confidentiality. All right, so sepsis is the most common cause of maternal death in Texas. So we talk about what really makes the maternal patient different. Well, everything does. So we talk about outcomes. We want to make sure that we understand that pregnancies that are complicated by severe sepsis and septic shock are associated with higher preterm labor, fetal infections, and preterm delivery. And it could be also a NICU stay for the baby if it's preterm above greater than like 36 weeks generally. What about a rapid decline? Well, patients, especially the maternal patient, they may appear very well and then they deteriorate because pregnancy often masks the signs of sepsis due to the biological changes that are going on in that body of the woman who is pregnant. So they may seem okay and they go really fast downhill. We want to make sure that we understand how quickly that it can go from severe sepsis to septic shock, and that MODS or death can occur within hours. So MODS is multi-organ, basically it's dysfunction systems, but it is what we used to call it way back in the day where organ systems were failing. We kind of call that end organ dysfunction now with a quick progression to shock. So it just goes to the different bodies. It can be, you can see it in your kidneys, in your lungs, but everything has a compensatory measure until it doesn't. And then that's when it progresses into shock. We want to make sure we can improve the outcomes of our patients. So how can we do that? Well, we can be really good at early detection of sepsis. The hour that if it takes more than an hour to recognize it, the mortality goes up by 8% for every hour they go without antibiotics. That's a pretty powerful number when we look at it. We want to make sure that we're recognizing a source. So is the patient have a UTI? Do they have an infection like a vaginal infection? What is going on? Even some upper respiratory infections can do this as well. So we want to make sure we're finding the source, that we're targeting our treatment for it, and that we are quick in our detection of this. So what is the difference? Well, difference is you have a voice and we want you to use it. We want you to be an advocate for your patients. Go ahead and go that extra mile. And really, if something does not feel right in your gut, trust your voice, because your voice is never going to lead you astray. So this is just some statistics over sepsis. So 47 to 50 million cases per year. That's a huge number, with at least 11 million deaths. 1 in 5 of those deaths, or 20%, are associated with sepsis, and it is the number one cause of readmissions, healthcare costs, death in hospitals, and the number one killer in the ICU. 50% of sepsis survivors have long-term physical and or psychological effects. So Carrie will hone in on this when she does her story, but that's the post-sepsis syndrome that we talk about. It's those long-term effects that are overarching that have an outcome on their life expand. 40% are cases under 5. So this 40% really means something to me because my daughter was one of those cases that are children. So it happens, we just don't think it happens that much. 80%, it's probably close to 85% now, that occurs outside the hospital and the community. So what does that mean? It means that we have to always be vigilant of sepsis when they come into our hospital, because it develops outside, but then they come into the hospital for care and treatment. Think also about your jail population, group home, homeless. Those are included in that 85%. So sepsis is always caused by an infection like pneumonia or diarrheal illness. And it's caused by an infection. I wouldn't say that it's only pneumonia and diarrhea, but it is an infection, and it really is overwhelming to the body. So what we want people to know is that sepsis is a medical emergency. If you know, or someone you know shows the signs of sepsis, seek medical care immediately and let them know that every single hour counts. This is the same as if you were talking about a stroke or a heart attack or trauma. Time is tissue. Time is of the essence. So some signs that may indicate sepsis. Excuse me. You can have slurred speech or confusion, extreme shivering or muscle pain, and a lot of that is due to just the metabolic process going on in the body. No urine all day. If you haven't peed all day, something probably isn't right if you don't have end-stage renal disease or CKD. You may feel like you have severe breathlessness, or you feel like you're going to die and that's the impending doom. You can have your skin that's mottled, so when you touch the capillary refill bed, it's 3, 4, 5 seconds because they're not getting the perfusion to the hands, and because everything is starting to shunt to the core. So if it walks like a duck, is it the effects of pregnancy or is it sepsis? So diagnosing maternal sepsis or post-delivery sepsis can be challenging because pregnancy and signs of sepsis mimic each other. So what we want you to know is that maternal sepsis is very, very dangerous to not just the mom, but the baby. So pregnancy and delivery changes. So we talked about it. Pretty much everything changes when you're pregnant. Some things just to know is this: your vascular resistance goes up about 25 to 30%. You have relative hypotension, tachycardia because of the increase of the baby putting on that vasculature, so it increases your heart rate. You also have can have some tachypnea, and that is just due to the increased body or increased pressure on the diaphragm, excuse me. And so that causes you to have an increased respiratory rate. And so keep that in the back of your mind as we talk about some things as we go through. You can also have altered clotting factors because of that systemic vascular resistance. So you can have just things that wouldn't normally be clotting the way it is, it now is because you're pregnant, because everything changes. So you may have some chills, or you may be diaphoretic post-delivery, and you can have some pain and dizziness. And that's all things that are kind of just happen when you're pregnant, but so does sepsis. So what are some symptoms, since we talked about the signs, what are some symptoms of maternal sepsis? So you can feel unwell. You can have lower abdominal pain that isn't the normal, like uterus growth. This is a distinct abdominal pain that's different. You can have foul-smelling vaginal discharge, and this could be due to a vaginal infection, a UTI, an STD that was undiagnosed. So anytime that you discover that, it's always good to have a culture done, talk to your doc, and see where you need to go from there. Any bleeding from the vagina, that is always a terrible thing in pregnancy. When you bleed, that typically means something isn't right, that homeostasis is somehow disrupted. So that's something that always needs to be investigated. You can have foul-smelling urine because, well, when you're pregnant, it's hard not to drink a lot of water, and you try to do the things, but sometimes you don't. So UTIs are really common when you're pregnant. So if you see that there's foul-smelling urine, talk to the doc, see what you can do, get a UA, and make sure everything's okay. You might get really dizzy. You might collapse because your vascular resistance is up. Maybe could be a number of things, but dizziness and collapse are always considered cardiac in nature until they're ruled out. So these maternal SIRS that we use at JPS are a heart rate less than 50 or greater than 110. We have respiratory rate less than 12 or greater than 30. Temperature less than 95 or greater than 100.4. White blood cell count less than 4 or greater than 18. And fetal heart tones are not actually a SIRS criteria, but they can be very indicative of what's going on with the baby. If they're having rapid decelerations or accelerations, it just kind of depends on exactly what's going on. But any kind of stress on the mom can be a stress on the baby. So we just want to make sure we monitor for that. Also, if you get a temp that's 92, generally it's could be the thermometer, I'll give you that, but it may not. It may be that they're really hypothermic and that they need to be warmed. So we've had several patients that have been super low temps, and that typically means that they're on the latter part of sepsis, where they go almost to shock because they're so sick. All right, so end organ dysfunction. This is the severe sepsis criteria. So we have our lungs, so any CPAP, BiPAP, intubation, that is considered an organ dysfunction. If you have any renal issues that are consistent, CKD, ESRD, it would be a creatinine that is greater than 0.5 from that baseline, but creatinine greater than 1.5 or urine output less than 30 mils per hour is for 2 hours is indicative of maternal end organ dysfunction. CNS, which is altered mental status. So this is not a CMS end organ dysfunction, but this is a telltale sign of what's going on. If your patient you get is not making sense, they're altered, they're kind of just fuzzy, somebody brings them into the hospital and says they don't sound right, make sure we look at all assets of what it could be for altered mental status. So cardiac, any systolic blood pressure less than 90 or a 40 millimeter drop below baseline or a MAP of less than 65 is considered cardiac end organ dysfunction. Lactic acid greater than 2.0, so 2.1 is also an organ dysfunction for both maternal and non-maternal sepsis. And then your liver. So if you have a patient that has a PTT or an INR that is increased and they are not on Coumadin, that's a problem, and that may just be that end organ dysfunction. If they have platelets that are less than 100 or a T-billy that's greater than 2. The liver and the platelets, and the reason those are inversely related is just because they go into what's called DIC, where they start making like little clots and they're becoming septic emboli, and it just kind of comes out of the liver that way. So be really careful if you have a patient that has an increased INR. So then what is severe sepsis? Well, we're going to talk about it. We start with 2 of the 4 SIRS criteria that are positive, which we talked about those. And then we add an infection, which is our source. It can be either suspected or confirmed. We add end organ dysfunction, which is what we just talked about. And you only need 1 of the end organ dysfunction criteria to be met in order to meet severe sepsis. And then once you've met it, your 3-hour bundle, which some of you might be familiar with, that starts. So once you have that, you have to do your 3-hour bundle, and it's the initial lactic acid, blood cultures, antibiotics, IV fluids, and another repeat lactic. So with all of that, I am going to introduce Miss Carrie, who is going to give her story about sepsis. So I would like to introduce her for a moment. So Carrie, on June 4th, will be a registered nurse for 20 years. She has worked her entire career with the Baylor Scott and White family. She currently serves in the role of value-based healthcare senior consultant, has a diverse skill set in several realms of the healthcare industry, and is a proclaimed data nerd. She's energetic, high-spirited, all-inclusive person that has a passion for both producing the high-quality outcomes and helping her peers to do the same. Ask anyone she works with what her job is, and you'll get 15 different answers. Her nursing background is in progressive and critical care and has approximately 12 years of nursing leadership experience. You name it, she's led it or tried to, with the exception of women's and peri-op services. Carrie became a fangirl for the lean management system methodology and clinical compliance standards. and served 4 years overseeing LMS initiatives. She has led several moderate to large scale projects and will step in to act as an interim nurse leader whenever needed, no questions asked. She currently serves as a sepsis coordinator for her facility, as well as assisting with clinical compliance standards. Her purpose for living is her husband of 22 years and her 10-year-old daughter and 6-year-old miracle baby son. She has 3 Maine Coon kittens, all under the age of 1, that provide lots of entertainment and hair. Carrie lives with life with purpose, gratitude, gratefulness, and passion. She is first and foremost a wife and a mom, and also happens to be a nurse who found her purpose in life by becoming a statistic. It is with my great pleasure that I will turn off my camera and I will turn it over to Miss Carrie.
Thank you. Hello. There's so many people on it. I'm so glad I can't really see your faces because I'm very fearful of public speaking, even though I'm this super high energy. When people tend to meet me, they're like, who is this crazy woman? And then they hear my story, right? And so then they're like, oh, okay, that makes sense, right? So I want to tell you my perspective, not from a nurse, right? I want to tell you my perspective as a patient and how sepsis affected not only me, but my entire family. So, as you see, that's my beautiful family there. So, ever have a hard day, and no matter what you're doing, you're like, how did I not pick it up? How did I miss that, right? So, in terms of maternal sepsis, it mimics normal, non-pregnant population, so much so that it is so easy to miss. And so I can totally see, and you're going to see too, based on my story and my data that I give you. My husband was a note taker, so just be prepared. I'm sure that he did a great job. You know how you tend to get to doing that when you see things that are wrong, but abnormal service criteria, typically, they're often disregarded, especially in that maternal role, because they're exactly the symptoms you would expect of a postpartum mom, right? Sometimes you may have a fever because of an epidural, right? So you wouldn't think anything about it. Your blood pressure may be, or your heart rate may be high, and that may be because of a quick volume loss, right? And just maybe pain associated post-op. So maybe your white blood cells might be a little bit high, which is to be expected, right? So you've just had this major surgery, and so you would expect for your body to do its miracle thing and try to help itself, right? So you wouldn't think anything about that maybe. Mild hypotension, depending on the patient, that's their normal. I'm not going to worry about that. But you wonder, then after the fact, right, we're servants and we want to do the right thing. And you're like, how did I miss it? So don't be hard on yourself. We are all humans. And I think that from my years of nursing, that what I have learned is that it's the story and it's the face. And so I am going to kind of walk you through what to watch for, what and who to listen to, right? And then I'm going to tell you what it looks like from my very own perspective. So I've told my story about 11 times, and I will cry because it impacts me still today. So sorry. Okay, no more. I promise I'm good. But what I want to tell you as healthcare people is that you are the advocate. If you have a patient and you know that something is not wrong or not right, you know that this one little thing may be off. And if people are disregarding you, you go up your chain of command and you take care of that patient. It's because most families and patients, they aren't medical. And so they're trusting us to take care of them, to get us through our whole pathway of our delivery of health, right? And so what is most important for you is stand up and do the right thing, even sometimes when it may not be the popular thing to do. Okay, so me give you part of my medical background. I did not want to put my pregnancy weight on there, so I'm just going to just say that. So, like, I am I have Hashimoto's, so my thyroid kind of affects like a lot of my vitals. So that kind of I'm giving you a little bit of piece of me. But before I was pregnant with my second child, my blood pressure was low bird. I was a low birder. People wonder why I'm always so low, but I'm just so much energy. But now I've just told you I'm a thyroid, right? Thyroid is a great thing. So my heart rate was consistently 60s or 70s. I tried to work out, or I thought about it. My weight hung around 135, and I had had 2 previous pregnancies, and I had delivered a kiddo prior to. I had a history of preeclampsia with my firstborn and delivered them at 37 weeks. And I was 35, and you're wondering that because you're like, she looks like she's 29, right? So how has she done all this? And I'm not really, I'm joking. So at the time I was 35. So second trimester of my pregnancy with my kiddo, my blood pressure was high. I had expected it. I expected it because of what I had gone through with my first pregnancy. My heart rate was higher, 80s to 100s, right? Which probably you would think might be normal just because of the vascular increase. And I weighed a lot. I gained a lot of, quite a bit of weight fairly early on. And so I was diagnosed with preeclampsia. And so then I got to hang out in the OB/ED a few times, and I felt like one of those frequent flyers, right? And so I've done everything I tried to do, but it was just hard for me to control my pressure. Okay, so if you are like me, I have got an extremely high pain tolerance, okay? And if you are like me and you are a nurse, we are the very worst patients at following any physician's recommendations, right? So I'm sitting here hanging out 33 weeks, okay? I was 3 weeks already into bed rest because I had passed out at a Mexican food restaurant, and my physician had said that is enough, right? Okay. So instead of being a compliant patient like I should have been, because I am a nurse, I opted to go trick-or-treating with my daughter because I wasn't going to miss that, right? And so now, all you mom baby nurses, which I'm not, just, I only walked maybe a quarter of a mile, okay? So we did that, and I got up the next day and I started having these back cramps. So I'm thinking, I guess that's very normal with progression of my pregnancy. So that went on for 2 days. So I went to the physician. I was having to go for 2 or 3 days a week. That was the give, instead of having to be admitted and hanging out with the great nursing staff there and being super bored. So I went to my scheduled appointment on a Monday. And so after my OB took a look at me, my fluids were up, and also my contractions were a minute and a half apart. So I was in active labor. I never had a contraction, so I don't even know what that even feels like to have a contraction in your belly. So I always had it in my back. So the OB then gets very nervous. Then I get very nervous because the OB is very nervous. And so she said, let's get this baby out because I've been up for a super long time and I have delivered a whole lot of babies. So I was taken quickly to an OR suite that was not used as frequently because the others that were used or that were in use were being used by elective deliveries, right? Okay, so I was prepped quickly. Okay, so we are having this baby. So I totally was not prepared for that, right? And so I've got all of this anxious, nervous stuff, right? And so I have this beautiful, sweet little boy. He's born, in the afternoon, and he was a wimpy white boy. And I know that you all know that that is real because he didn't want to breathe and he didn't want to eat, and he just wanted to, he wanted for us to do everything for him. But are you paying attention to what I'm telling you? Okay. So here is what I have learned in my nursing career is that if a family member says to you, something's not right, it's not. And so we tend to disregard things, right? It's just because of the pressures that are put on us, the tasks that we know that we have to do. And so we may just be so busy, but listen to your own voice, listen to your soul. And if something doesn't feel right, normally with you, it's probably not right. So in the instance of patients and families, it's the same exact thing. Okay. So I had popped that baby out, and I was about a day and a half post C-section, and I started having a ton of pain, okay? And so I noticed I was a little bit short of breath, but I was still a little bit chunky because all of the fluids hadn't gotten off of me. And I told the nurse that when I'd had my other C-section, I was ready to go home about a day after surgery, right? And so I told her something's not right. I feel like something is wrong. So think about what you think she said to me, okay? My concerns were dismissed, right? And my husband was frantic. So he is my rock. We are the very bestest of friends. He knew that something was wrong because he has been with me since I have been 16 years old, right? So, and he knows I have super high pain tolerance, right? But nobody would listen, okay? So here's my vitals. Are you worried about me? Okay. You ever have those regrets of like, but you just didn't listen, right? Listening is not the same thing as hearing. And we hear things when we're busy and we're trying to multitask, and it's nobody's fault, and it is what it is, right? But hearing is also not the same thing as listening. Okay. So here I am about post-op day 3. I continued to have pain. And even though concerns were starting to be raised, more so, we continued to be dismissed. And it was very normal to have pain, okay? The provider wasn't called about my pain or the low-grade temp I had developed, okay? An assessment was not performed on my belly to take a look at it, but if she would have looked and pulled up my gown and the blankets, she would have seen some of the worst streaking that I have ever seen in my life that started at my C-section wound and went clear up to my sternum, okay? And so if you have ever seen that, that is a big deal, right? There are these super bright red lines, these streaking lines. My incision was very bright red. It was very angry. We say those are angry incisions sometimes, or angry wounds. And my brain fog started to kick in. And so I am used to brain fog. Like I said, I have hypothyroidism. I like to prefer this to cotton candy brains, what I like to call myself, But this was when things get very, very kind of foggy for me, and I forget details. And I was told, that I had done things that I did not quite remember doing, But here's my vitals, right? My blood pressure 90/58. So, my prehistory. Are you worried? Probably no. That's her norm. That's good. Her heart rate's up because she's hurting, right? So that's normal. Respiratory rate's normal. My temp. It was 99.9. So nothing to really, truly be concerned about at that point. Okay. Okay. So now this is when I have not remembered. I don't remember anything. So it was early in this day. I do remember that because people kept asking me what day it was. But they become very extremely cloudy for me. But there is one thing that I remember from this day. And it's loss on this big, strong, super husband guy of mine, that is my best friend, and I couldn't help him. But that is burned. It's burned into me. So I completely had the impending doom. I was like, I'm going to die. I felt like I was going to die, and I was okay because I felt too bad to even help myself. It's like, I am this sassy type A, strong will, love to argue with the physicians just because I get them riled up, that's me. But I felt so bad I couldn't even take care of myself. Okay, so here's my vitals. So my blood pressure was low, 82/39 about, and this was just a few that he had taken down. My heart rate was high. My respiration stayed okay. My temp was 102.7. My vital signs weren't taken frequently, but my serum lactate, which was drawn at the insistence because a friend demanded that they draw lactate on me, was 6.3. So that quickly is like how quickly. That is why the times are so important, right? So you think, why are these so important? Well, because look at how quickly that I deteriorated. Okay. So I have, full disclosure, I have pictures of some of my wounds. I did have a picture of me intubated, and I just could not tolerate that. So I pulled that out of there. So if you don't like to see the wounds, then I'm sorry, but I want for you to see kind of what I went through, but I also want you to see how I progressed. And so, post-op day 6, or so, they called an RRT, and I was moved to the intensive care unit. And I was diagnosed with severe sepsis with septic shock. So I was intubated for 5 days and put on norepi to keep my pressure up. And I had my second IND, and I guess during that time, and they swapped a wound back on me. Oh, but here's something I forgot to tell you, super important about the other. So when they finally did reach out to the physician prior to moving me, okay, it was an on-call provider, and they came in and they gave me Dilaudid, and I remember telling them, that hurts, right? And so what happened was my IV was infiltrated, but my wound was cut wide open at the bedside. So basically it was like I had nothing for pain. And thank goodness I do not remember that pain. I remember the act, but I do not remember the pain, that pain. So, okay. So what do you think, though, if we can go back real quick, was wrong with me? So they drew blood cultures and I was positive for MRSA. So I officially right now am a statistic. So I'm one of those numbers that we all talk about monthly in our HAI meetings, right? But, I like to say I'm not really a statistic. I'm just me. So I recovered, though, fairly quickly after that IND, and actually was discharged home from the emergency or from the intensive care unit. And I had a wound vac and I had a pick in tow. So I get this super awesome equipment to get to take home with me. So some of you are probably like, where's your baby? Well, he's hanging out in the NICU because, I'm a wimpy white boy. Okay. Okay. Look at that sweet girl. Those girls, everybody wishes that they could have those, right? So I continued to feel bad after discharge. I felt bad. I didn't feel good. I didn't want to get up. And you would think, that I was progressing and that my care was on plan. And so my husband, being the guy that he is, calls all of my little nurse friends, and then he calls the physicians and he says, something's wrong. And so I went right in, and my incision had gotten real angry again. And so the physician took me in, and I developed an abscess, and he had to go back in there. So that was my third LND. And so I am so blessed for my husband, and I have no qualms to know that he saved my life a few times, because after this LND, the surgeon told us the reason that I was not progressing was because the wound vac was doing a phenomenal job of healing and creating new tissue, but it was over necrotic tissue. And he said as bad as the wound was that I was probably about 3 weeks from death at that point. So I knew I felt bad, but I could not do anything, about it. And so the picture of my wound, the left one is that little abscess that they took for me, but that, or the right, I'm sorry, well, actually that is our left there, but on the right side of that picture, that's that dead skin that they cut out. By the time the third IND had been done, I had to be cut hip to hip. And I was cut almost down to my bladder. Okay. But here's the great news. I started to feel so good after that. So it's amazing, right? Okay. So can we go back? Because I want to talk to you about how it affected my family. Can you go back? There you go. So this beautiful girl is just like me, and she drives me crazy because she's just like me. But I want to tell you, this is the story. This is the part that I really want for you to listen to me, is because, you know, I had a home care nurse that was coming 3 times a week. And she was nice, but she was by no means a wound care expert. But she tried her hardest, and she knew. I was, prior to having that, the third IND, and for a little bit after, I would have to load myself on narcotics, an amount that should have killed people, right? And so I remember that I would have to take, 40 of OxyContin and 100 of Tramadol and then 0.5 of Xanax. And I dreaded it. And the wound vac changes from then are seared in my head. And so I still have nightmares about the pain of that. And then I learned, prior to having that third IND, I shouldn't have had that pain. But it worked me up so bad. And then even after, I would still be in pain, so the narcotics really didn't do anything, but I don't feel good, right? So I don't know any different, and I'm not a nurse right now. So, but here is what we think, okay? So we give a patient, and not on purpose, a bug, right? Maybe from a CVAD, or maybe from a Foley. And so we identify that we have made an error, right? Because nobody intends to do anything on purpose to harm patients. It's just not in our servant nature. So we treat it, and we think that they're better, and we send them off, but they're not. And we don't think about who else besides the patient is affected, okay? So I've got this little sassy chickadee here for me. And during my wound vac changes, she would hear me scream because it would hurt so bad. And so one day she brings me these 2 stuffed animals. Sorry. She told me to be strong. And it completely broke my heart that a 3-year-old is that perceptive, and is that affected. But I think that actually that helped to make her stronger, and why she says he liked me now. So, but I had to have when it came time for my son to come home, I had to have people take care of me. Okay. And then I had to have other family help to take care of my son. So I'm also now putting out my family, right? And so it affects so many people, and it's not independent of just one person that you think is affected. So I'm sorry if I cry. Please give me grace. It's just it happened, right? But I'm grateful. So we'll talk about that a little bit more. Okay. So here's great. I'm not a wound care nurse, but I kind of learned to be. But here's just some great progression of my wound. So about 2 and 3 months, you see, it went great. I did inadvertently have a few more abscesses, but nothing really major. So, okay, there's 4 and 5 months. Aren't you thinking, oh my good gracious, what is going on, right? Okay, next slide. Okay, this is what I love to call my lovely equipment. So do you know that a wound vac costs about as much as a car? So it really does. And so I had a wound vac for about 5.5 months. Okay. So if you can go back to some of those pictures real quick for me. I'm sorry, we're going to go over. I don't mean to. You can go back. So you see all the red around my wound. So I developed an allergy to adhesive because of the tape, right? Because it has to be secured. So, okay, we can go back. So I have this wound vac for about 5.5 months. I am a self-proclaimed wound vac queen because I have fixed leaks I didn't think that were ever possible to fix. So I was on IV antibiotics for about 4 months, and then I had to transition for about 2 months. So, and then I had this really cool little contraption called a Pico wound vac. So it's like a semi-permeable dressing, and it's changed weekly. And I had those for about a month and a half, and it's that charge of that's about $5,000. So, but I was embarrassed by that because since it's semi-permeable, sometimes wounds smell bad, and so I didn't kind of want to go out. But after 7 months, I rang my wound care bell at my wound care clinic, and I got this really awesome graduation certificate. And so I'm golden, right? And so I'm ecstatic because finally there's a normal. Okay. In healthcare, in our roles, sometimes we do hurt people and we don't mean to. 1 in 3 people will be affected by a medical error in a hospital. That's a statistic around the country, right? We're humans, and we are so task driven, and we give you so many tasks to do, and it's amazing of what staff can do on the floor, and they do it well, and they do it with compassion. And so we think at the same time, though, we can fix that unintentional harm, like I said, right? And then they're fine, but it's not fine. So I haven't forgotten what happened to me. As you see, I am still extremely emotional. Some days are very bad for me. But most days I try to win. Just depends on the situation, but I'm the face of harm. But I'm a survivor. So my sweet family is harm. And so because of what I went through, I've diagnosed PTSD. And for both myself and my son, that's a different story because we're all about me today. The emotional toll of what I went through, it still bothers me, as you can tell. Some days I'll have these random flashbacks, and it's very, nothing brings it on. There's no triggers. But most days I'm fantastic, right? But it's been almost 7 years still. Okay. So I'm always waiting for the next thing to happen. What medical issue is going to happen next? What's next? So I went on like that though for really about 3 years until I finally got over it. The look on my husband's face, I see it all the time. The look of loss, of grief. And I don't ever, my goal after I was able to come back to work was that never anybody that I ever took care of would have that look. Okay. I'm angry because I didn't get to take care of my son, right? But I'm grateful. And so, yeah, you can see the rest of the stuff on the slides, but here's my sweet family. This is my sepsis survivor story. We have a lot of fun. I'm a wife and I'm a mom first. I'm a nurse, but I'm a statistic, and I am harm, And prior to all of this, I was a burned out nurse. I know we overuse that word, but I was a nursing leader and had a lot of responsibilities. And I know a lot of you all have how that feels. But this completely refocused my drive to be better in both my professional and my home life, right? And to set my priorities. And so I'm able to look at issues from both sides of the patient and the nurse perspective, and I can sympathize. So a lot of us empathize, right? I sympathize. And so I understand the importance of listening and listening for keywords. So, but I am grateful. I am sorry that I got emotional. I really try to not do that every single time. But I appreciate you signing up and listening to my story. I don't know if Patty wants to get back on. So I know that there's questions that, so what do you think the nurse told me maybe? So if you wanted to type a comment.
Carrie, this is just
Yes.
thank you so much for sharing this. This was an amazing story, and I'm sure that everybody on the call shares their sentiments with me as well. I want to give some time for Carrie to do question and answers, so I'm going to breeze through these next couple slides, but we just wanted to summarize this up, and the biggest thing we want you to know is that maternal sepsis is deadly to both the baby and the mother. Early recognition saves lives. Look for the signs that are there, okay? Look at your patients, listen to them, and look at your incision sites. Just remember that it is not, don't forget to look for the signs that are not obvious. Don't ignore the voice within you telling you something isn't right. And then use your tools that are offered within your organization. Sepsis can happen to anyone, anywhere, regardless of socioeconomic status, background, medical training, or family connections. It can happen to me and it can happen to you. This is the contact information for both me as well as Carrie that I wanted to give you in case you come up with some questions and we run out of time. And then now would be a great time for question and answer. So let me get to those. I don't see.
This is Patty. If you have a question, you can type it into the chat.
Thank you so much, Patty. These are the references that we used for this. If you would like a copy of them, I can send them to you. And then I will just put this up that our next C for next month with our JPS and DFW hospital collaboration is going to be Joni Patton with the sepsis predictive analytics on June 29th from 11 to 12 as well. All right.
Well, there's one thing that I can tell you is that I can share some stories, is because, like I said, I share my story with everybody, and it's, I don't want you to feel sorry for me, because man, I am sure lucky, and I'm grateful. But what I want you to do is to take one thing back, and so you think as a mom baby nurse, and I do not know your world, you are very strong women to do that, but I had a nurse that listened to my story. She had a friend from California that called her, and she's telling her about her dad, right? So her dad's not feeling well. And so after hearing my story, and she would not have done it prior to, but she told her friend it sounds like it could be sepsis. So not just moms, right? So everybody. So he went to the facility, or to a hospital, and he was diagnosed with sepsis because of a complicated UTI. So, just that listening to people, and then applying that to practice. So.
Thank you so much, Carrie. This I think I've heard this story, I think like 4 or 5 times now, and every single time it brings me to tears. So if you'd like any more information, just let me know. You can email Patty at the Data Valley Hospital Council, or me or Carrie. So if there are no more questions, we will give you 2 minutes back in your day to do